And we can go to the next slide. So I'm Amy Miracle. I'm a research scientist in the Alcohol Research Group at the Public Health Institute. I co-lead the I-STARR project with Dr. Carmen Masson, who's a professor of psychiatry in the School of Medicine at the University of California, San Francisco. But the team also includes co-investigators Sarah Zemore and Lenny Jason, biostatisticians Mina Subbaraman and Libo Lee, and communication specialists Diane Schmidt and Dustin Kebzu. They do all the magic at these webinars behind the scenes. Our project coordinator is Quinoja Capitani. Let's go to the next slide. So the I-STARR project activities are also guided by our 17-member advisory board, comprised of a diverse group of leaders from across the country. Our advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, as well as researchers and educators. Some of our advisory board members may be in our audience today, but many of our advisory board members also serve as presenters in this webinar series. Let's go to the next slide. So before I introduce our presenters for today's webinar, we'd like to do some quick polling to get a sense of who's in the webinar and how we can best use this time. As you can see on this slide, there are just 3 questions in today's poll, and let's launch the poll now. The questions are basically, who are you? So we can get a sense of your role in respect to recovery housing. We also want to know, have you participated in a research study before? So that could be completing a survey or an interview or participating in a focus group. We also want to know if your residents or your recovery housing organization has participated in a research study before. After you answer those questions, you may have to scroll through to see all of the questions. Just hit submit and close out the poll. And once we get a good representation of results, we'll share them with a larger group. And here they are. Okay, so interesting, we have a good mix of folks here. Most are recovery residents, operators, and staff, but we do have some clinicians and some researchers as well. So we have quite a few. 2/3 of the group looks like almost 2/3 have participated in research before. And then in terms of your organization, your recovery house participating in research, we have the majority have not. So I think this is good. I think this will be a good mix of folks for folks who have participated in or collaborated in research for you guys to share your experience in that process, and for folks who haven't to learn about what that process is all about. So let's go to the next poll or the next slide. The next poll. No, we're done with polls for now. Without further ado, I want to present today's presenters. In addition to myself, you'll be hearing from one other presenter, Elizabeth Mahoney. So I'll present some pretty dry information on what constitutes research, the types of things that researchers worry about when conducting research involving human subjects, as well as other things that you might contemplate if you're thinking about participating in research or collaborating with researchers. Finally, both Liz and I will present some examples of projects that we've involved that have involved different levels of collaboration with the recovery housing community. So for folks who don't know me, in addition to co-leading the I-STARR project, I've also been conducting research on recovery housing of all types and all across the country for about 15 years. I studied at the University of Michigan and the University of Chicago and completed postdoctoral studies at the University of California, San Francisco, where I became acquainted with work being conducted at the Alcohol Research Group before heading off to the East Coast to conduct research in Philadelphia. In 2014, I found my way back to California and began collaborating with Doug Polson and his research on California sober living houses. And that's where I got to start working with Liz Mahoney. In addition to conducting research on recovery residents, residences here at the Alcohol Research Group, I also serve on the Public Health Institute's Institutional Review Board, where I learn something new about human subjects research every time that group convenes. So that's a little bit about me. Let me tell you about my colleague, Elizabeth Mahoney. Liz is a research project manager in the Behavioral Health and Recovery Studies program at the Public Health Institute. Liz received her undergraduate degree in psychology from Boston College and her master's in psychology from the University of Denver. Liz is currently managing 2 different sober living house studies, one funded by the National Institute on Drug Abuse and the other funded by the National Institute on Alcohol Abuse and Alcoholism. She previously worked on another study focusing on an intervention for sober living house residents involved in the criminal legal system. And prior to joining the Public Health Institute, Liz worked at the University of Pennsylvania Center for Studies of Addiction. So with those introductions, let's move to the next slide and launch into the topic of participating in research. Let's go to the next slide. So what do we want to make sure that we cover in today's webinar on this topic? Well, primarily 3 things. First, we want to give you information you would need to differentiate research from other activities you may engage in that involve data collection from your residents or about your house. And the reason why this is important because research involving human subjects is highly regulated. So we'll spend some time reviewing these regulations and entities designed to protect individuals who participate in human subjects research. We also want to talk about things to consider if your house or your organization is contemplating collaborating with research and human subjects research. Let's go to the next slide. So folks tend to use the term research to mean a variety of different things. Indeed, in the day-to-day operations of our recovery residents, folks engage in a number of activities that involve collecting information from and about their residents. So this could be information collected at intake, which could even involve standardized assessments. And it could also involve information collected at discharge in terms of satisfaction surveys, or even post-discharge questionnaires. What is most important when thinking about whether an activity constitutes research is not necessarily the type of information collected, although that does come into play, but rather how the information will be used. So most folks who are collecting information from residents are likely doing it to ensure that they can provide the best possible support to residents during their stay. That's not necessarily research. That's you just being a service provider and making sure that you can provide recovery support planning. Now, you may also, across residents, be compiling information so that you can say something about your program, different types of services provided, or different types of individuals served. You may, for example, want to demonstrate to your stakeholders that your program is doing what you set out to do in its mission statement, or that something that you've introduced in your program is having kind of the desired effect. Things like program evaluation, quality improvement initiatives, while they can be, are not necessarily research either. So what differentiates these sorts of activities from research is that research is or refers to a systematic investigation, including research development, testing, and evaluation designed to develop or contribute to generalizable knowledge. So the key terms here being systematic investigation, in that aims and procedures are clearly outlined, and that findings from this work are intended to generalize beyond your residents to say something larger about recovery housing or residents who live in recovery housing. And again, why would such distinctions be important? Because research involving human subjects, and that's nerd speak for people, is federally regulated. Let's go to the next slide. So why is research federally regulated? The short answer to this is that we've seen what can happen when it's not. For example, unethical experiments on prisoners in concentration camps during the Holocaust spurred the issuance of the Nuremberg Code in 1947. Guidelines continued to evolve after that as ethical concerns were raised about research, such as with the Tuskegee syphilis experiment, the Milgram experiment, and the Stanford prisoner experiment, just to name a few. So in 1964, the U.S. signed on to the Helsinki Declaration, further delineating ethical principles for medical research involving human subjects. And in 1979, the Belmont Report was published in the Federal Register. So the Belmont Report summarizes ethical practices and guidelines for human subjects research in the United States. The Belmont Report identified three primary concepts. This is respect for persons, beneficence, and justice. And these three principles are reflected in attention to informed consent, assessment of risks and benefits in research, and the selection of human subjects in research. And the Belmont Report is important because it serves as the backbone of the Common Rule, published in 1991, which codified Health and Human Services Regulations 45 CFR Part 46. Let's go to the next slide. So before I go any further, and I want to apologize in advance if I've slipped into some acronyms already, I do want to review some terms that are very common in the parlance of human subjects research that might otherwise sound like gibberish to folks who are new to it. For example, CFR in the phrase 45 CFR 46 refers to the general and permanent rules published in the Code of Federal Regulations adopted by departments and agencies of the federal government. The Department of Health and Human Services is often shorthanded as HHS. The Office for Human Research Protections, OHRP, provides leadership in the protection of human subjects involved in research conducted or supported by HHS. The Office of Human Subjects and Research Protections provides leadership on human subjects research within the National Institutes of Health, which you'll hear referred to as NIH. So other terms you'll hear about in this webinar are FWA, which stands for Federal Wide Assurance, and IRB, which I think I've already said, stands for Institutional Review Board. And we'll go over both of those shortly. Let's go to the next slide. So let's go back to the Common Rule, 45 CFR 46, Subpart A in particular. Subpart A provides a robust set of protections for research participants. Specifically, it describes the type of research subject to regulation. It defines key terms such as research, human subject, and minimal risk. It requires a written assurance of compliance with the regulations in the Common Rule. It sets forth requirements for an institutional review board's membership, authority, review procedures, and records, as well as criteria for approval. And finally, it lists requirements or general requirements for informed consent. So there are other parts to the 45 CFR 46. Subparts B, C, and D provide additional protections for certain populations in research, and Subpart E provides requirements for IRB registration. But the main part is Subpart A, and again, that's referred to as the Common Rule. Let's go to the next slide. So how are guidelines set forth in the Common Rule enforced? So the first layer of enforcement is through the use of federal-wide assurances. And again, that's the FWA. Through the FWA, in terms of the FWA, an institution conducting human subjects research commits to HHS that it will comply with the requirements in the Common Rule. The federal-wide assurance, the FWA, is the only type of assurance currently accepted and approved by the Office of Human Research Protections, or OHRP. So how does one get an FWA for conducting human subjects research? Well, you can apply for one, and I've listed the website here. And it's been a while since I worked with an institution in obtaining an FWA, but it is possible for non-academic entities who want to do research to obtain one. Another route for folks to ensure that their commitment to uphold the common rule is registered with HHS is through reliance on another entity also involved in the research that holds an FWA. Let's go to the next slide. So the FWA is a statement or an assurance that an institution will comply with guidelines set forth in the Common Rule in 45 CFR 46. But the entity doing all of the work to ensure that research activities comply with applicable regulations, meet commonly accepted ethical standards, and adequately protect research participants is the IRB, the Institutional Review Board. It's the IRB that determines the type of activity a researcher is engaged in, meaning whether or not activities constitute human subjects research, as well as the type or level of review required by the IRB. It basically reviews, approves, and monitors human subjects research activities to ensure that they are consonant with the principles outlined in the Belmont Report. Let's go to the next slide. So one of the activities IRBs engage in is ensuring that researchers who submit their research protocol to be reviewed and approved have the requisite training to be conducting the human subjects research. And all personnel involved in the design or conduct of human subjects research must receive training in the protection of human subjects. How does one receive such training? Well, again, the Office of Human Research Protections, OHRP, offers a variety of free online trainings on human subjects research protections and requirements on the revised Common Rule, 45 CFR 46. IRBs may also require that you complete other training, and the most commonly used training is that provided by the Collaborative Institutional Training Institute, or what's called the CITI program. Next slide. So this is a lot of background information on research and protection of human subjects in research, but what does this have to do with participating in research? Well, I'm hoping that this background information is helpful in guiding your decisions about whether you, as an operator, might want to participate in research. And that could be by completing a survey or an interview or participating in a focus group. Or if residents from your house are being asked to participate in research. So as I mentioned earlier, one of the key topics addressed in 45 CFR 46, the Common Rule, is elements of an informed consent. So unless researchers are granted waivers by an IRB, individuals who are being invited to participate in research must be told a lot of different things in what is called a consent form. So they should be told what is involved in the research, about potential risks and potential benefits of participating in the research, whether there are alternatives to participation, how confidentiality of information will be maintained, whether there's compensation for participation in the research. They should be told who to contact with questions or concerns about the research. And there should be a statement in the consent form that participation in the research is voluntary. It's up to the person who is being invited to participate in research whether or not they want to participate in it. Let's go to the next slide. So participating in a research study as a human subject aside, what about collaborating with researchers to conduct human subjects research with your residents, for example? Well, to give you a brief framing, I'll talk a little bit about levels and models of involvement weighing involvement with regulatory responsibilities, and how these sorts of partnerships or relationships can be memorialized. Then I'm going to have Liz come in and walk you through an example of ways in which she's collaborated with recovery housing and conducting human subjects research, and I'll chime in with another example as well. Let's go to the next slide. So the graphic on this slide is actually not something I created, but one that I borrowed from an earlier I-STARR researcher training on community-based participatory research that was led by one of our advisory board members, Kathy Berlew. So Dr. Berlew used this slide to illustrate that on one of the end of the spectrum is research that's purely driven by the researcher. And on the other end is research that's driven by members of the community, as well as everything in between. So that training, because it was directed towards researchers, focused on pointing out the benefits of community involvement and considerations for researchers when working with community members. I think this graphic may also be useful in thinking about how community members, in this case, recovery residence providers, may think about their involvement in research. Let's go to the next slide. So I would contend that figuring out where someone is on this community researcher collaboration continuum has a lot to do with balancing one's desired level of involvement with commitment to take on responsibility for protections of human subjects participating in the proposed research. And this really hinges on whether the institution or the community member, in this case, the recovery residence organization, will be engaged in the human subjects research activities. So thankfully, the concept of engagement is something that OHRP provides guidance on, and most definitely something that IRBs would be weighing in on. So in general, an institution is considered engaged in human subjects research when its employees or agents, for the purposes of research, obtain data about the subjects in the research through intervention or interaction with them, obtain identified private information about the subjects of the research, or obtain informed consent of human subjects participating in the research. And again, why is this definition of engagement so pivotal in the researcher community-based partnership so critical? It's because institutions engaged in research must hold or obtain an FWA and certify IRB review and approval of the research. In other words, people who are engaged in research have responsibilities in the protection of human subjects in the research and upholding regulations specified in 45 CFR 46. Let's go to the next slide. So regardless of where you land on the continuum, on this continuum of partnership with a researcher, when partnering with a researcher in human subjects research involving your house and residence, I would encourage you to develop something that outlines the nature of this partnership. So at a minimum, this document should specify who is doing what and when. It should specify how human subjects regulations will be upheld, as well as compensation for any costs incurred during the research period. This can be memorialized in lots of different ways: a letter agreement, memorandum of understanding, an MOU, or even a contract. So the exact nature may be dictated by the institution initiating the research, but the content of this agreement should be, agreed upon by both parties. Let's go to the next slide. So with that overview of human subjects research protections and information important to know when considering participating or collaborating with researchers and conducting research, I want to hand things over to Liz to present an example of research partnership with houses in the Sober Living Network in California. Off to you, Liz.
Thanks, Amy. Okay. So I'm going to talk about an example of community place research where our team collaborated with sober living houses in Los Angeles County. So next slide, please. So I was the project manager for Dr. Doug Polson, the principal investigator, aka the PI, So he had worked as a therapist and gotten involved with researching sober living houses, and he found that residents who were on probation or parole had good outcomes, but not as good as the other residents. So he designed a study to see if an intervention could help this population. So he thought of motivational interviewing, or MI, where a therapist works with clients with substance issues to find reasons for changing their behaviors. And then many sober living residents also reported wanting connections to services to help with their recovery, but those systems can sometimes be difficult to navigate because they're so complex. So he modified the MI to add a case management focus to connect them with services, and he called it motivational interviewing case management, or MICM. He then got funding from NIDA to see if this intervention could help improve recovery outcomes for this population. So the study was first reviewed by our IRB, and then we began recruitment. We first recruited the houses, and then we approached the new residents to see if they were interested in participating. So the houses for the study were selected from members of the Sober Living Network, which was a local nonprofit organization of sober living houses. We targeted houses that had a large number of residents involved in the criminal justice system, and we would have the houses sign a letter of agreement. So this was more of with what Amy was talking about, more of a simple document that communicated what we were asking them to do. It wasn't legally binding, but it helped us really document what we were asking and that they had agreed. And then for the resident inclusion criteria, we required that they have current legal system involvement, so on probation, parole, or involved with drug court. And then since this population also had a high HIV risk, we also included those who were HIV positive or had other HIV risk behaviors, including any injection drug use or any commercial sex work. So, and since we wanted to be able to compare how they were doing prior to the sober living and after, we also required that they move in within the last 30 days. Another aspect of the study was randomization. So when you want to see if an intervention is better than not doing the intervention, aka treatment as usual, you conduct a study where people are randomly assigned to receive your new intervention or assigned to a comparison group, which is called the control group. And so this is referred to as randomized controlled trials. And researchers love these. They're kind of considered the gold standard because they allow you to look at the cause and effect of an intervention by offering that comparison group. So we decided to randomize at the house level for this study. So we used a computer program to randomly assign a house to either group, and then any resident from that house that was then enrolled in the study would be in that group. Next slide, please. So here you can see the study team. So on the left is Dr. Polson, the study PI. So in general, the PIs plan and lead the study. They usually have a doctorate, so an MD or a PhD. And they're ultimately responsible for the conduct of the study, but they can delegate tasks to other team members. And so then on the right, you can see who he delegated the data collection. And so that's me with the 3 of the interviewers. And so since we went into the community to conduct research rather than having participants come to an office or a clinic, we referred to that part of the research team as the field team. And that's usually led by a study coordinator or a project manager, which was me on the study. And when each person, the interviewer, would then be assigned to a house once the house signed up for the study, so they could have consistent contact with the team member. There are also other study team members not pictured here that participants never meet, such as statisticians, but all the team members have to do that city training for human subjects protection that Amy mentioned earlier. Next slide, please. So outlined here are the visits involved in the study to get a sense of what happens. So step 1 for getting into the study is screening. So we'll ask all the new residents a few questions to see if they were eligible. And so as I discussed earlier, when I was outlining the eligibility criteria for the residents, we had some potentially sensitive questions around their involvement with the legal system and HIV risk behaviors that we had to be sensitive around. And then the next part is the baseline interview if they qualified for the study. And that one is the longest visit due to consenting and usually asking more background questions. So then we also collect all the different assessments, and those are based on prior research. And those questions are, usually closed-ended. So yes or no, rate on a scale of 1 to 5. How many days did you use in the last 30? And everyone gets asked the same questions. And there are some questions on there that are a little bit also sensitive, such around like trauma and suicidality. So interviewers get trained in handling difficult situations, but Dr. Polson would also be available. And then after that, then they would go into either their the MICM group where they'd see a therapist, or the control group where they'd be given a list of resources. And then at we then do the follow-up visits and contact them at 6 and 12 months. So we followed up with all participants, even if they left the house. So this is called an intent to treat design. So those we would look at whether, like, we want to look at whoever enters the house, not just those who stay for the whole time. And that one is just to make sure that we can see what happens with anyone that enters into the house. And then they're done after the 12 months. So no more, if they were in the MICM group, they would then be done. And then there would also be some contact in between the visits there to make sure that we gathered other information that we needed. And then next slide, please. So for the level of involvement, so this one we would say was active but not engaged. So the houses were the recruitment sites, but we didn't have any of the staff there conducting any interviews. Their involvement with the recruitment was the posting or the dissemination of the study promotional materials. And then for data collection, they would provide space for in-person interviews. And for follow-up interviews, we could conduct them over the phone. So then if they were at the house, we would try to have them find a quiet place there, since we would be asking sensitive questions. And then we would also do some interviews with the house managers to get their perspective. And so because none of this was involved, like with the house people working there, no regulatory activities were needed for the house. And then next slide. And so what did we tell the research sites? So on the left, you can see part of the letter of agreement. And then on the right is our flyer. So this just kind of gives you an idea of how we would approach the houses, kind of letting them know that we knew that they were busy. And we know that a lot of people here have different ideas of research once they hear the word research. So we wanted to make sure that they kind of understood that. That was just, we wanted to make sure that we had that letter of agreement in place before we started. So we had that understanding. Next slide, please. All right, so here are some of the questions that we received from the houses. And this is, just good to kind of keep in mind whenever you're approached about participating in a study, is what exactly they're asking you to do, how they're funded, and their background. And some of the houses started asking us for the consent so they could kind of see what we were saying to the residents. And so I think that the consent has all those features that Amy mentioned earlier. And I think that that is a great source of information also for houses that might be interested in participating in a research study to get an idea of what they're doing. Next slide, please. And here's a quick summary of some of the challenges we faced. I think the biggest one was establishing those relationships with the houses. This process took a lot more time and required a lot more driving around LA than anticipated. As I hinted at, we asked a lot of those sensitive questions. And so that also could be off-putting for some, and people could get upset that they didn't qualify for the study. Luckily we had a great field team and they were great at establishing rapport. So we were able to, complete our study goals. And we also had other people at the houses that would then vouch for us. Once one person would do it, it would then kind of snowball after that once they got an idea. Another big challenge I hinted at earlier was we had a lot of ineligible houses. We were looking for houses that met our criteria, and we were also very fortunate there with houses referring us to other houses in the sober living network, helping us out. And also kind of with, the background of kind of research that hasn't been done that well, you never know what other people's experience has been with research. So people could be leery. Next slide, please. So here's a quick summary of how the house recruitment went. Pretty much you can see we started off with those 396 houses, and we ended up with about 25 in the MICM group and 28 in the control group. Next slide, please. And here you can see some of the ways that we thanked houses. And we laid out in that letter of agreement how we would pay the houses for their time and their resources. And we just decided to base that off of how many people we were able to get into the study from there. And next slide, please. All right, and so in summary, here's a few of the pros and cons of setting up a study this way. So it's definitely less resources than if we had house managers or residents as interviewers. We didn't need to train all the house managers. So it's a difference of training about 48 people versus those 3 you saw in the picture. And then this also meant that participation of the houses was not that big of a commitment. So even though we had difficulty recruiting, it was a little bit easier where we were able to say we weren't asking them to spend time interviewing. And there's also less potential variability. So with more people involved, the more potential for procedures to kind of lay out from the protocol. And as far as the cons, kind of what I talked about with the challenges, the buy-in was a tough obstacle. And if we'd had people at the houses who were trained to conduct the interviewers, then residents may have been more likely to participate or be honest in their responses. But there's also then that nature of the relationship where they're still living together. Also, we would have a little bit of delay in sometimes getting the house news and less of a sense of involvement for the houses. And so for the study results, we'll have a link to the paper at the end, but now I'll pass it back to Amy to present an example with more house participation.
Excellent. Thank you, Liz, for an amazing example of recovery housing research where residences were actively involved with the research team, but were not technically engaged in the research being conducted. So the example I'm going to present is from a smaller study, but it's one in which recovery housing or the recovery housing organization was engaged in the research being conducted. Let's go to the next slide. So this is a study that focused on a segment of the LGBT community, that being men who have sex with men, shorthanded as MSM. And the backstory behind this project is that I was approached by a colleague, one of the presenters in this training series, Jason Howell, about studying a recovery residence in Austin, Texas, that was specifically for gay and bisexual men, but operated by a provider who had several other homes for both men and women. So not only was my curiosity piqued about how a residence for gay and bisexual men might operate, because I hadn't heard of anything like that before, but I was also curious about how gay and bisexual men made decisions about which recovery home they wanted to live in, and whether there were differences in outcome with this segment of the recovery housing population based on the type of residence they entered. So I've listed the aims of the study on this slide, but I've also listed all the different types of human subjects activities involved in this study. So these activities included recruitment of house managers to participate in a structured interview about their residences, recruitment of current residents of the gay men's home to participate in a focus group, screening and recruitment of incoming male residents to participate in phone interviews at baseline and follow-up, recruitment of stakeholders for semi-structured interviews, and administrative data or records review for the MSM who enrolled into the research study. Now, to say that there were many pieces and moving parts to this study would be an understatement, but complicating things further was that my team was conducting this research based in Austin from California. So let's go to the next slide. So this research hinged on the Austin Recovery Housing Organization helping us with some key recruitment and data collection activities on this study. So in terms of recruitment, we needed their help in posting and disseminating of study promotional materials, facilitating the collection and secure storage of resident screening information, facilitating researcher recruitment, or the recruitment informed consent of eligible participants, which was done by us actually remotely. But we also needed their help with data collection activities, like providing space for in-person remote data collection. We also needed their help in pulling administrative records from folks who gave us permission to look at them. So the amount and nature of involvement by staff at the Recovery Housing Organization kind of tipped the scales towards meeting the criteria for engagement in research. As such, my institution, the Public Health Institute, engaged in an FWA reliance so that institutional assurance by the Recovery Housing Organization to uphold the common rule was in place. They basically used the FWA for PHI. We specified an agreement to do that. My IRB also arranged for recovery housing staff members involved in the recruitment and data collection activities with human subjects to be properly trained and certified. Finally, expectations for each party, particularly around the human subjects activities, were memorialized in a letter agreement. So let's go to the next slide. So what did this letter agreement look like? So in the next few slides, I've redacted and pasted in elements of this 2-page document that spelled out expectations and responsibilities of the Recovery Housing Organization, as well as the researchers. So regarding the organization, it specified what was needed regarding facilitating recruitment of the house managers at the various recovery homes, as well as what was needed regarding recruitment of the current residents in the gay men's home to participate in the focus group. Let's go to the next slide. It also went into detail about what was needed regarding screening males entering the houses and facilitating recruitment and data collection from those who were identified as gay or bisexual to complete surveys with us. And finally, it also provided details regarding pulling the data from their administrative records for residents who had enrolled into the study. Let's go to the next slide. So in addition to spelling out what was expected of the Recovery Housing Organization, expectations for the research team were also spelled out. In my mind, I wanted to make sure that I listed all the things that the research team would be doing to make things as easy and painless for the Recovery Housing Organization as possible, as well as formally documenting that we were shouldering the responsibility for the majority of the human subjects research activities. So if the feds came looking or came wondering about the human subjects research activities, they would be coming to us. Let's go to the next slide. The document also included information about how the organization could reach out for support and information, as well as details regarding compensation to the organization for time and resources. Let's go to the next slide. So the information on the slide contains recommended best practices for researchers working with recovery housing operators and human subjects research. It contains principles that I always try to adhere to in my recovery housing research and what I train others to do in their recovery housing research. Now, folks in this audience are largely recovery housing operators, but these are things that you should be on the lookout for when you're considering partnering with researchers. First, researchers should be making collaboration as easy as possible, particularly if this is a researcher-driven project. You guys, your hands are full already providing the service that's being studied. Second, work should reflect a partnership with shared investment in the aims and the research questions. Partners should be working with each other, not for each other. And whenever possible, shared decision-making and how there should be shared decision-making in how to conduct the research. And when there can't be, and sometimes there can't because things just need to be how they are, there needs to be transparency about why. And finally, communication is key. There should be regular check-ins about how things are going and open lines of communications between these regularly scheduled check-ins to avert any potential problems. And it's also important to share study findings. Providers may be particularly critical to interpreting research findings, but also about thinking next steps in the future research. So I like to think again of solid research being solid and good research on recovery housing being built on a strong partnership, collaboration, mutual respect and support, and I try to impart that in the work that I do. So let's go to the next slide. We've really tried to cover as much as we could in the context of an hour-long webinar, but there's so much that could be said on the topic of participating in research. So to make sure that you guys have access to additional information on this topic, we've pulled together some resources where you can dive in and learn more. Let's go to the next slide. So this slide contains information on journal articles on some of the studies discussed today, additional human subjects resources, and where you can learn about different research being conducted on recovery housing. We've also tried to paste in these resources into the chat along the way, but we'll drop them into the chat here now so you can just click and go to them easily. Let's go to the next slide. And finally, I want to hear from you guys. So given what you've heard on this topic, I'm really eager to open things up so that folks can ask questions about human subjects research, about participating in research, and about collaborating with researchers in conducting human subjects research. And for this, feel free to raise your hand and unmute yourself. But we can also, we have folks monitoring the chat, and we can you can also just drop your questions into the chat. And I see a hand raised already. Trent Thomas, do you want to unmute yourself?
Yes. Can you hear me?
Yes.
Okay. I am a provider here in North Carolina. I actually have started a residential mental health and substance abuse treatment facility for adult men. And I was wondering, this is my actually my first experience with the whole subject of research in our facility. So how does the process begin, and how do you actually become involved with using your facility as a research host?
Yeah, that's a really good question. One I hear a lot. So how do you get connected with a researcher? Well, some shameless self-promotion. We're hoping that the I-STARR project will help facilitate that. For example, we have trainings for researchers. We have trainings for providers. Next month's webinar is actually bringing researchers and providers together to talk about how we can do more and better research on specifically medications for opioid use disorder in recovery housing. I think that any opportunity that you have to connect with other researchers, to attend webinars and trainings that researchers might be involved in, I think is a way to just get a sense of who's doing what in the field, so that you might get a better sense of who you could approach about conducting research on your program and with your residents. I hope that helps answer your question a little bit. And Liz, feel free to jump in.
Are you wondering if about collaborating with the research or starting doing your own research at your center?
Well, what would be the purpose of doing my own research? How would I use that information?
I mean, that's kind of the great place to start. So if it is something where you are, I think Amy had hit on at the beginning, if it is something where you're interested in improving your own procedures, that is sort of a different line of thinking. If you're interested as far as like getting involved with being a part of a research study, that is more you're being involved in sort of contributing to more like the generalizable knowledge that she was talking about.
Okay.
And so that's sort of the difference. So it's kind of like what part are you more interested in doing? I mean, you could, you could be doing both, but if you're interested in kind of contributing to the more generalizable knowledge to kind of, have your place be a research site, that would be, a different path that would require a lot more of what we kind of laid out today with all these different regulations and everything.
So now, is this state specific, or is it pretty much the rules apply countrywide?
It's
countrywide. Federal regulations.
Okay.
Yep.
Yeah.
Okay.
Yeah.
All right. So the researchers, is there a website I could go to find out who's doing what research and how I could join that study?
So again, shameless promotion. I would direct you to the I-STARR website. One of the things that we hope to do, and we'll talk about this a little bit later, is that folks who attend the training series, who get trained up as a researcher, who get trained up as a recovery residence operator or provider, will list those researchers and those providers on our website to, again, facilitate that linkage between folks who are doing really high quality recovery housing to folks who are trained up and interested in doing research on recovery housing. Again, like I said, shameless promotion, but I would direct you to the I-STARR website. Liz, what other recommendations and resources would you think of?
I think the one that we had in the in the one slide, just the NIH reporter, in there that has a list of all the National Institutes of Health people that have received funding, and that can kind of give you an idea. It might be that they're already conducting studies, but it could be something where, you know, you could reach out, you know, put in the different search terms in there to kind of see anything you'd be interested in participating, and could try reaching out that way just to see if any of them are looking for research sites.
Okay, so now that hints at my next question. So far as the cost of being a research provider and any funding that would be appropriated for you know, committing to a research, you know, how does that work?
So that would,
yeah,
you can
go ahead, Liz, go for it.
Yeah, that one would be that would be laid out with whoever you're working with, and it would depend also on kind of that level of involvement, and that's something that would be, you know, as far as like you're training your staff, they're more involved versus, you know, more as like a recruitment site. So that's it varies that way. Amy, I don't know if you wanted to say anything further.
Yeah, again, so research, the largest federal organization that funds research is the National Institutes of Health. And so the research that Liz and I do is funded through the National Institutes of Health. And so that's where we get our funding to do our research. But when we're partnering with folks who have recovery housing organizations that we want to partner with, then we would set up contracts and discuss kind of the level of involvement, what's going to be entailed in the activities the house is involved in, and then we would determine kind of what would be fair compensation in that letter agreement or that contract or that memorandum of understanding.
Okay, that sounds great. Now, how do you handle the HIPAA regulations when it comes to dealing with your clients?
That is a really good question. We have research participants. So HIPAA is something that tends to be clinical and kind of focused on the provider. The information that we collect in the context of our research study is covered by kind of the confidentiality procedures that we've set up in the context of our procedures and the data that we're collecting. If we're collecting data that is collected by the organization, then there is some HIPAA stuff that goes on, but that is kind of only if we're collecting medical records information. Liz, do you want to add anything to that?
Yeah, we tend to have our own, we're collecting our own, like for the study that just to speak the ones that I've done, it's our own set of data. So for us, we're not asking the houses to share anything with us. So in that way, we try to keep everything separate. Like we're not sharing any of the information.
So let's, for instance, if you're doing a research study on opioid abuse, you would need to know if the clients are suffering from that illness or not, I would assume, right?
So that's part of the, so for us, it's more, that's why what I was saying, the part where we just tend to try to interview anyone new that comes in. So they, like the houses don't have to share any of that information with us. For us, we then are collecting our own and interviewing them.
Okay.
So it's everything. Yeah. So that's why we have that whole process of screening to see if they're eligible to see for the study, just because we're really trying to have it as a separate thing. So the houses don't have to get involved with that part. But there are, as Amy hinted, there are other ways of setting it up where it would be a little bit more, the HIPAA would be more involved if it did involve sharing of data with the House.
So these are all really good questions, and I hate to cut off the Q&A and discussion portion of the webinar, but we do have some other stuff that we want to get through. So if you do have additional questions, please feel free to drop them into the chat so that we can tackle them. And if you want us to get back to you, feel free to leave your email and we'll respond back to you with your questions. So let's go to the next slide. So just some announcements about what's coming up on the I-STARR project. We have one more webinar this month. It's a webinar for actually researchers, but it's going to be flipped on its head, just like we flipped this one on its head for providers. So we're actually going to have providers presenting at the researcher training webinar this month, and it's all going to be about what you guys do, the challenges of operating and managing a recovery residence. So next month, and I alluded to this, we're going to actually bring the researchers and the providers together to have a discussion and to be able to ask questions of one another, kind of summarize what we've learned in this series thus far, so that we can talk about how we can expand an agenda to actually do the research that we need to do on medications for residents taking medications for opioid use disorder and recovery housing. So that is I-STARR stuff coming up. I just want to also plug that the National Conference on Addiction Recovery Science, the NCARS conference, is coming up in April. That's a virtual conference at the 24th and 25th of April, and registration is still open. We dropped into the chat how you can register for that conference. And finally, I also want to mention that in addition to this training series, the I-STARR project also supports research, pilot study research. And we have one of our pilot study researchers here with us today. Let's go to the next slide, and I want to tag in someone from the Mo I-STARR study.
Hi, thank you so much for that introduction, Dr. Miracle. So my name is Rashmi. I'm here on behalf of the Mo I-STARR study, which stands for Missouri Infrastructure for Studying Treatment and Addiction Recovery Service Residences. Basically, we're trying to see what sorts of barriers recovery houses might be faced with in supporting or implementing medication for opioid use disorder. These barriers can be attitudinal, capacity related, anything in between. And for that, we're hoping to get somewhere in the range of about like 200 responses from operators and 200 responses from residents. Our recruitment structure is a little convoluted. So essentially, the link that I'm about to drop into the chat is a link that recovery home operators can use to take part in the survey. After recovery home operators take part in the survey, we do reach out to them over email with a new link for residents in their home to take part in the survey. That way we don't have to compromise anyone's confidentiality, and we're able to sort of understand what barriers might be happening in any one particular recovery home based off from the perspective of a resident and from the perspective of an operator. I do also have our email at the bottom of that. So if you have any questions about the study, please contact us at moistar@umsl.edu. And please let me know if you have any questions. Last but not least, please do not post this link on social media. We've had some issues with some fraudulent responses, aka like robotic responses online. So if you could avoid doing that, that would be perfect. Feel free to also forward our information to anyone in your networks. We're really just trying to get the most number of responses that we can so we can paint a really clear picture as to why MATs are not more widely implemented in recovery homes. Thank you.
Wonderful. Thank you, Rashmi. Let's go to the next slide. So I just want to remind folks again, this is one webinar, part of a series of 12 different webinars that folks can register for. If you complete the whole series, you not only can get a certificate, an I-STARR certificate, You can be listed on the I-STARR website as someone who's completed these trainings, but we'll also give you an accounting of your attendance so that you can send that off to NADAC for CEUs for your time participating in these webinars. If for whatever reason you've missed some webinars, you haven't been able to attend live for all of them, we have our websites or our webinars on our learning management system, and this will track participation. It's a little bit more of an interactive experience so that you can ask questions, you can drop notes in the chat. It's a little bit better than just viewing our websites that are webinars that are posted on our website. So I encourage you to check out our learning management system and to get registered for the entire series. Let's go to the next slide. And I think that's it. We are 1 minute past the top of the hour. Thank you for hanging in there with us. I hope that you guys come back to another webinar. We have the researcher webinar later this month, and then next month is the all audience webinar, and that will be the first Tuesday of the month in May. So thank you so much. Take care.